Good afternoon. Thank you very much for the organizing committee for inviting me. I have to say, to start with, I've been impressed before I start. The organization is beyond perfect to start with. Really great. Thank you very much for this. My talk is going to be on integrated care for older people, for the elderly. I am an old age psychiatrist through and through. I'm a clinician, I lead a service. I've been leading a service for some time. Most of my patients are older adults. The younger of them have dementia, so I also deal with young onset dementia. So I'll be talking about the demographics, demographic changes in older population, how is it like to be old, challenges in the current model of service provision, and proposed models of care. I have no financial disclosures. I have no relationship to any product or companies I may mention in this presentation. And I would like just to gauge the audience, if you can scan this. It's not going to take long. Okay, so to start with, the first question was if you work with older adults. So 29 of you never, hardly work with older adults, 12 once or twice a month, 3 once or twice a day, 14 mostly every day, and 4 elderly care constitutes my main care work. Yeah, I would like to see those people. Hello, hi. Yeah, good to see you guys. Good to see you all. The other question was about really the age expectancy at 60. So I'll tell you the result. So let me go there and I'll tell you the result. So I'm sure you know, at least have some notion that there have been increase in the population of older adults in the last century. So, and even recently. So it took France doubling the population of the elderly 100 years, but now doubling the elderly from China, I think taking 5 years or something like that, 25 years, something like that. So doubling of the elderly population is huge. That was the gained life expectancy at birth. So in the last 60 years, I think at birth, people gained 40 years, am I right? 40 years in the last 60 years. But if we compare older adults, so how many years of life older adults gain at the age of 65 in the last 60 years? Only 5 years. Yeah, this is great, but still dwarfed compared to 40 years. And if you see this, that was a surprise for me. This is COVID, guys. This is COVID. The issue with the challenge with healthcare is, though the population of the elderly may be small. So in states, for example, the population of the elderly is 1/6 of the population. They take on 30% of the health budget, which is expected. And this number is going to increase with time. And the challenge with healthcare or care for the elderly, it's not only health, it is care. It's not only mental health, it's not only physical health, it's not only social health, it is care. So care and well-being. You can't separate them in older adults. Very difficult to separate them. All models that separate them, and I have fellows working in the UK as older adult consultant, they don't work well and they leave gaps and patients are missed. Dementia is my core business. So if we imagine that dementia is a country, dementia is a major illness that affects older adults. If we imagine that dementia is a country, this country would have nearly 60 million population. And it would have a newcomer every 3 seconds. And the population would double every 25 years. And this number really at the end really boggles my mind. So it costs the world economy 1 trillion. 1 trillion is the economy of Saudi Arabia, Kuwait, Bahrain combined. It's huge. And we can't afford not to do anything about it. Coming to UAE, around 10 million. Okay, it's in the working age population is predominantly male, but this difference in gender really start to disappear with age. And we have nearly less than kind of 100,000 elderly person above the age of 65. That's 1%. The thing is, this figure is going to be 16%. So from 1% to 16% in less than 30 years time. So this is 16 folds or 1,600%. It's huge. And with that, there will be a mushroom of the expenditure and need. Okay, these are estimates, these are calculations. So if we don't take the 65, we lower it a little bit to 60, we have 250,000 person above the age of 60. And that makes the estimate number of patients with dementia 16,000. And if we extrapolate, so in the UK, each person with dementia really costs the economy 32,000 sterling pound per year. This is the average, direct and indirect cost. So if we extrapolate, that would cost here, Emirates, 2.5 billion dirham per year. So what happens with people when people grow older? Things start to slow down and senses start to be less acute, as well as the cognition start to slow a little bit. It shouldn't affect function. It should not. Not everyone who's elderly has dementia. In fact, most people who are above the age of 85 do not have dementia. The rate of dementia above the age of 85 worldwide is kind of a quarter, which means that 75% do not have. Frailty is another problem. It's a major problem. Still only 25 to 30% of people above the age of 75 have frailty. But the problem with healthcare or care or aging, the problem is complex. So there are illnesses that do not fit clear categories. For example, falls. Falls is a major problem in elderly. The rate of survival for people who have a significant fall is between 25 to 50% within 2 years. It means that probably if a person had a fall, they may die 50%, but the probability of them dying is 50% in 2 years. It's significant. It doesn't fit the category though. And that's why treating it as an illness doesn't work. Other things that I see a lot, I work in mental health and I see a lot, is loneliness. And I have, it comes to my mind 2 really stories. I had a patient who I deemed to have resistant depression. She came to me at I joined, I think, the team at 2019. She was on 3 antidepressants. She was always weeping. Her daughter said that she wept most of the time. And I thought that she did not respond to 3 antidepressants. I was thinking of adding lithium to augment. Anyway, came COVID, and her daughter had to stay home with her. And she's no longer depressed. It was a misdiagnosis. She was so happy with it. When her daughter, who works as a doctor, started to work again, we knew that she needed someone she can talk to. And she's no longer, I think, on antidepressant. I can't remember. I don't think that she's on antidepressant. She's in duloxetine for something else, for incontinence, but a low dose. And having befriender worked. I didn't know that loneliness can kill like smoking. I didn't know that before. I have a patient right now admitted for a social reason because she lives on her own. She has issues with her in-laws, so she doesn't like to go to her in-laws. And she shops with doctors. So she goes to doctors and she passes her time. She was admitted because her family are unable to cope with her, but it's an assessment admission and she will be discharged soon. Her issue is loneliness and boredom. And this is a major thing. And it takes resources from mental health. It takes resources from healthcare. And I think family physicians may be aware of that. I don't know the experience of family physicians, but I would imagine they may be aware of that. This is a common experience. So that's what I was talking about earlier. So there are things that elderly people suffer from. They do not fit a category of illness. They do not. And the management of it, prevention and management, is not a medication or a condition that I can fix and send the patient home. It doesn't work like that. Doctor is not enough. Physiotherapy is not enough. Social care only is not enough. It needs multi-agency work, multidisciplinary team, integrated service for it to work. So we were talking about vulnerability, but vulnerability in elderly is not the rule. I was just mentioning that 75% of people above the age of 75 are not frail. 75% above the age of 80 do not have dementia. But what we see, because we are physicians, we see the sick, we see the unwell. Doesn't mean that the rest of the elderly have this. In fact, I want to share with you this. So this is Julia. I think she was 105 and she ran a sprint, 100-meter sprint. Yes, and we're just saying who ran a marathon above the age of 100. We see those things. We don't see them as a physician. We see them in the community.
Okay. All right.
Good luck.
Thank you.
On your marks, set. All right, here we go, here we go. Here we go, here we go.
Mama, back up here. Yeah, you're good. You're good. You're right in there.
You're doing great. Julie, how did it feel?
Wonderful. I'm so happy.
What should we take away from this? What should we tell our listeners and viewers about what we saw today?
Well, just stay healthy and keep running. And I'm going to keep running as long as I can. I find it fun. I like doing it.
Recording the race. And she managed to get 100 meter, and she was very happy about it. And she said that as long as she was going to live, she's going to take part in this race. Moving on, those are the healthy, but we deal with the unhealthy. It is upon us to prevent illness, to promote wellness. So this is important, what we can do. And that doesn't start in the office of a doctor. It starts as a community, as a preventative measure. So I was talking about that common problems with the elderly really do not fit one specialty, do not fit one service, and they need multidisciplinary. That was said. And that's why the current, or the common rather than the current model of service does not serve elderly well. They have a lot of social care needs, they have a lot of mental health needs, and they have a lot of physical health needs, and they are intertwined and they cannot be separate. I find it very difficult to separate them. And that's why along the speech, I'm not going to say health service, I'm going to say care service. So the design of most services in most countries is there's primary, secondary, tertiary service, and acute or secondary or tertiary is hospital-based, and there is the community, there is social care, and the funding is different, the model of working is different, and the organization and the management hierarchy is maybe different. In the UK, at part, I think, good part of the country or good part of the trust, mental health trust, we have partnership trust where social care and mental health care provided together as one unit. This is a model, but most countries really, social care is separate than health care. And I don't know any default country that is the standard is the integration of all forms of care. Even in the UK, it's some trust, not all trusts. Okay, so, and this is another issue, is the healthcare workers and the training. So healthcare worker, the way we train is, how I trained is, There are chapters in books, there are illnesses, and each illness has treatment and prevention sometimes, but this is how we think, how we have trained. And we are trained to fix the illness, and that's why sometimes when families or patients come to see me, they ask about a cure. I'm not sure that we can offer a lot of things. We can make their lives easy, we can help them to improve, resolve depression and other things, but cure is very elusive. I don't think that in medicine we have cures except in infections, and that is even proving to be difficult. So what is the response to that? So this is really from the WHO. So they propose a model of service that considers health and well-being needs as one entity, and for all services to be coordinated or integrated. And it's not about the illness, it is about the person's needs. And all of that needs to be addressing the prevention, the management of conditions, and the tertiary, which is reducing the burden of illness on patients and caregivers. And all of that needs to be delivered in effective and efficient, sustainable way. Other than that, it will be fragmented service. And I've seen that so many times because I see patients in a governmental hospital. Some of my patients go to private doctors, and each doctor treats his illness. So cardiology, there's cardiology who treats something, and there is neurology who treats something. And I've seen it. I've seen patients who are prescribed anticoagulant, aspirin, clopidogrel, and they were on SSRIs, and the lady had severe GI bleed. No wonder why. So we're talking about this. So this is the WHO proposal, which repeated again, it focuses on the person's needs and goals. It focuses on integrative approach to all care needs, social and otherwise, and promotes comprehensive delivery of care across several levels. So in primary care, the proposal, or not the proposal, the model suggested is first to try to maximize intrinsic capacity of people, to try to prevent them from getting unwell. And that's what was Professor Norman Sartorius talking about. So Dr. Meisner earlier talking about prevention is a great thing in elderly. And we can prevent a lot of diseases. So this is one thing. Early detection and management of health issues and well-being related conditions, and reduction of burden of illness. So these are the three goals. And those are the principles. So preventative and proactive. Preventative means that we need to do something to promote health. Unfortunately, previously, most of the research was talking about risk factors, not strength. So we always try to reduce risk. I don't think that the literature is as rich when it talks about strength factors and how we promote them. I don't think that the literature is equitable. So this is one thing. The other thing is active case finding. So rather than waiting for patients to complain or caregivers to complain, we need to actively try to find those cases early before they are symptomatic or severely symptomatic, and to try to treat. This is secondary prevention. The second point is community and home-based care. Part of my job as an older adult consultant or psychiatrist is home visits. That is what I did. This is part of what I do, what I did. I enjoyed it. I think patients appreciate it. And I found a lot of things that I would have not been aware of if I did not see patients in their environment. And I don't think that delivery of care for the elderly could happen remotely. I don't think so at all. It's not only about care, it's providing all of the care, not only social care, all of the care. Self-management, which basically is empowerment and enablement. So we try to educate patients about the risk factors, about their illness, about what works, and about what doesn't work, and trust them to manage their illness with a lot of boosters education session. It needs to be personal and relevant to the patient or the caregiver. And I remember having a patient having a patient and his wife. The patient did not sleep, but this did not bother the wife. The patient, I think, had a lot of vocalization. What bothered her is his apathy, that he did not talk to her. For me, as a physician, apathy is there. If a person is grunting, vocalizing, or doesn't sleep, for me, this needs, but her needs were opposite. And I don't think that if I did not address the apathy, either won't be happy. And that reflected on her relationship with him, and they started to fight. Comprehensive, collaborative, multidisciplinary. I'll talk about these things in a little bit details: community engagement, innovative, and outcome driven. So that's what I was talking about. We need to try to promote health, see what reduces the risk of illness, reduce the risk of ailments, and try to work on it early in life and in primary care. And I think we are working now on case finding for patients with dementia, active case finding. But it's not only dementia, there's diabetes, hypertension, other things. And I think I've seen a slide in the morning about the effect of reading on cognitive functions. They quoted 37%. Well, we can, the literature say that we can reduce the risk of dementia if we take care of those factors, reduce it by up to 50%. And this is a consistent finding, but those things need to be addressed early. And the other thing that I was not aware of is physical inactivity is more harmful than smoking or obesity. So those things, if we don't take care of them early, they will become illnesses later. And this is part of what we do. In the UK, I don't know if in the States this is available. In the UK, GPs were able to prescribe physical exercise groups. For patients with dementia and memory service, I was able to prescribe physical and mental exercise, both combined groups, and it worked. And the thing that was good there is patients also socialized, so they felt less lonely. They were looking forward to intervention like that. And the take-up on those groups were much higher than the donepezil, rivastigmine, galantamine, and the rest of medications. And it gave meaning and purpose for patients. I spoke about this earlier, which is community and home-based care. It needs to be delivered in the patient's place of living or close to, and that's why integrating, and that's the model I enjoyed working, and I felt that I can see more fruits to it, working within primary healthcare, working in GP surgeries in the UK. I had access to the GP, we spoke. In fact, that reduced the number of referrals because GPs could just see me in the corridor, talk to me about the patient, advice, done. I did not even need to see the patient. So that reduced my workload. And the relationship between me and the GP or in the state, the family physician was much better than a letter of referral. I know that people who work in the UK receive those letters. Enablement, so systematic self-management support. So yes, treatment, but also enabling patients, enabling caregivers to take control of their health conditions, to know about it, to know the skill, to learn the skill, and to know how to manage it. People feel empowered. And when they feel empowered, they are more engaged. And the outcome, there is the evidence to indicate that the outcome is much better when people engages with, understand what's wrong with them. I see that because I see patients with dementia who go to doctors or who go to physicians and they give Aricept, they give rivastigmine, and they don't tell them that the condition is going to get worse with time. They don't tell them that. And that's why those patients keep going to a doctor, following a doctor, and a doctor looking for a cure. No one told them that there is no cure. This medication could reduce the progression of the illness to some degree, could enable you to live independently to some degree, but it's not a cure. There is no cure. And this is very uncomfortable to talk to patients, but I think we need to have the courage to tell patient that sometimes we can do a lot. We can make you live happier. We can make you live less able or to enable you, but really chasing cure is a futile endeavor. The other thing, the other value is working in the area between what is needed and what is required or demanded by a patient. So the area of need and demand. Not everything patients require, they need. Similarly, not everything I can offer, they want. If we want to take an example of that, for example, the lady I was talking about, the lady who had her husband having apathy, what I was offered is not what she wanted. And we try to work within this overlap of needs and demands. And that needs conversation with the person concerned. What is, okay. It's 000, the screen here. Comprehensive care, yep. Comprehensive care means care for the acute, subacute, chronic, and the thing that I personally feel that it's not really offered as much here is palliative care. I don't know the design of health service in Abu Dhabi, sorry, but my feeling is there is need for palliative care, and palliative care for elderly people who do not have cancer. They have chronic painful condition that is debilitating, that could make person suicidal. And I had a person, again, saw him last Wednesday, a person who was in and out of hospital, severely debilitated, stayed in bed most of the time. He was on 3 antidepressants again, it did not work, and he was suicidal. The thing that worked for him is buprenorphine patch, which is a painkiller. And honest to God, he was praying for us all yesterday. He was very grateful for that. No one addressed this. He was depressed. Yes, he was depressed, but the underlying cause for his depression was pain, unaddressed pain. So what I'm saying is, a lot of the work I do is palliative care. I think we need to start from prevention, and we need to address palliative care, because there's a lot of money that's spent in terminal conditions at hospital. That does not improve quality of life for patients at all, does not prolong their life in any meaningful way, does not. They die with people who don't understand. They don't understand what's happening around them. If I was going to choose how to die, I would like to die with my loved ones. And I think that model could be looked at. So really addressing palliative care as much as we are interested in preventative care. This came out in 2018, and I'm very fond of this because I started to see significant changes. So this is the senior citizen strategy of United Arab Emirates government. It's several legislations and policies aim first thing, high quality healthcare, then social connectedness, then improvement of the experience of elderly citizen, offering infrastructure, having financial security, ensuring that they are protected, and there is a law now for older adult protection, and ensuring that overall they have good quality of life. I'm not going to talk about the collaborative models, how they work. So this is funding. Multidisciplinary work is important. I'm not going to say important. I need to just explain something. We work in different ways. In the UK, for example, I did a lot of mental health act assessment. Mental health act assessment had to include another doctor, another colleague, and a social worker or approved mental health practitioner. Our roles were different. So our rules were to see if the patient had a mental illness of a degree and nature that warrants hospital admission either for assessment or treatment. So this was the focus of our assessment. The social worker had a totally different role. The role was to balance everything and to protect patient rights. Sometimes they disagreed with me. I totally respected that. I understand the role. They were working within the remit of the role, protect patient rights. They have to balance other things. And the clarity about the roles of people really reduces the conflicts and the dysfunctional dynamics that could happen with teams. That was really good.
Cogstack is essentially an interrogation tool to interrogate existing datasets. A little bit like Google, it acts as a search engine that allows you to type in a very simple textual command, interrogating data across multiple platforms, for example, laboratory result data, clinical text data, and data that exists in hospitals and primary care. I'm a rheumatologist and we look after people with a disease called rheumatoid arthritis. One of the most common medicines we use for this is called methotrexate. So we've been very keen to have a way of monitoring people who develop renal impairment and be able to identify them and stop the methotrexate before any harm happens, to create an immediate reporting system. And this has resulted in, for example, quite recently, a patient got an email alerting me that she had been admitted, her renal function had deteriorated, and she was still taking a methotrexate. I was immediately able to contact one of my registrars who stopped the medicines, preempt the potential problem and harm.
I'm Matthew Hotoff. I'm Director of the NIHR Biomedical Research Centre at the Maudsley. I think that in the future this is going to be revolutionary in terms of the way in which clinical information is used for clinical decision making, because it does three really important jobs. One is to improve patient safety by alerting clinicians to problems before they've recognised they're happening. The second is that it potentially allows for early intervention because you can spot a pattern of deterioration in the clinical state and intervene earlier and thereby improve patients' lives but also potentially save money. And the third thing is because it makes information available about the whole of the patient's journey, you can actually provide more holistic care. You can bring mind and body together.
And community engagement. So this is different from community service or community care. So I worked in a place in the UK, West Bromwich. So in West Bromwich, a lot of Sikh community. So I had dealings with community leaders. They invited me to funerals. They invited me to the gurdwaras. And connecting with those community leaders helped me to provide better service for them. And just mention something. I think last year I received a phone call from one of their community leaders, wanted to talk to me. I was here for 3 years. Wanted to talk to me about a patient. I could understand them better. They could alert me when things were not going well. So working with community leaders, it's not just important. We are deemed experts, but we don't have the credibility of the community leaders. And we need to borrow from their credibility to work. Last, outcome-driven funding models. So rather than focusing on numbers of sessions, because numbers of sessions, I can really see 35 patients for 5 minutes in a non-meaningful way and push my numbers up. This does not serve patients. The funding or the incentive need to serve the outcome, improving general health, reduction of falls, reduction of adverse side effects, improving their mental and physical well-being, societal. And also that was part of the innovation. This system used in the Maudsley SLAM in the UK, consultants could see the general health of their catchment area. They could see the discrepancy between their prescription habits to their colleagues. So I can compare myself to my cohort, and I can see how my interventions reflect on the population, my catchment area. So I'll send you that. So what can we do? Just know the patient well. I like the term family medicine, family physician. And the UK GPs, or at least GPs I worked with, they knew the patient and their families. So they knew that Mr. Smith and Mrs. Smith did not get on well. And they had really deep, impressive knowledge about their patients and what they want and what they didn't want. And I loved it. It helped a lot. But the transactional healthcare does not work. So a patient comes, prescribed, then goes, and another. Yeah, this is part of business, but knowing patient well, knowing patient deeply really works. Comprehensive assessment, I was going to talk about comprehensive geriatric assessment. You can check that. Setting goals that are relevant to patient and what we think should happen. Empowering patients, enabling them to self-manage their issues, their problems, their health issues, and providing regular follow-ups and looking into care comprehensively, not just healthcare, not just mental health care or physical health care, just care. I had a mentor in the UK, Paul Babington, who believed that medicine must be social. It can't be otherwise. And I appreciated that in him, because my notion previously, before I trained in the UK, that my job was to prescribe. I know that what I do as an older adult psychiatry is I de-prescribe. I stop medications, and it works. It works. So, again, integrated model has those values: preventative, community-based, and multidisciplinary, if I want to summarize it. And on that, thank you very much.